The morning now will be taken by two medical speakers at the beginning and a third one after the coffee break. First we welcome Professor Patrick Hunziker from the University Hospital Basel, who will speak about intensive care medicine in the era of hypothermia, organ replacement and machine learning. Patrick, pleasure to welcome you here.
Thank you very much for the words, for the invitation. I'm very impressed by the dedication on this important topic you are working with. And I want to state I'm not a transhumanist, but Patrick told me that this is not the absolute precondition to tell you about my experience at the edge of life and death in intensive care medicine and in the edge of technologies to prolong life, to improve life. And so I would like to show you some insights in
the button to the left. Yeah.
What going on in our clinic and in our minds. I'm an intensivist, cardiologist, trying to save patients who are on the point of death, also by invasive means. I'm also the president of the International Society of Nanomedicine, trying to implement, translate nanoscience developments for the benefit of human health. I'm involved in several high-tech spin-offs from our research, and I'm also involved in a number of projects bridging the first and the third world as a kind of background. Now, the next thing will be a movie. Please, I'm not I cannot show this on the internet, and we should not record this. So this is for your eyes only, so please stop the recording for a moment so that I can... in this situation we have three options. The classical option is to resignate, everything is lost. The second option is to apply the precautionary principle, say we do only what we know for sure that it's good, and in medicine this never applies. We very rarely know if an intervention we are doing or if a drug we are giving is really good for this individual patient. And on this side of individual patient management I will also shortly shine some light later. And my view is that in many cases we want to move forward based on limited knowledge. In some cases this means I believe it's hopeless, so we abandon ship. In other cases we try to apply things which are known and also things where we don't know yet if they are good to kind of save a life. Now, here you see a patient, such a patient, it's a different patient a little bit later. This patient also has a myocardial infarction with circulatory arrest, but now he's undergoing a PTCA, a balloon inflation, balloon dilatation of his main coronary artery. The problem is, under these conditions, we have a very low circulation and it's very difficult to perform this intervention, and usually there is no reflow to the coronaries and the patient will die anyway if you do PTCA, anti or automatic chest compression. And that's why we have introduced a few years ago miniaturized catheter-based artificial heart pumps. And I will pass one of these pumps through the rows. These pumps pump between 2.5 and 3.5 liters of blood per minute through the body. They alone are sufficient to maintain a life for 24 hours, even if the own heart does not work. And we have a few hundred of patients where we have seen that. And so we are now able to kind of make the bridge a little bit longer than the first few minutes with such a chest compression device. And this will be the future in cardiac support, because currently this technology is translated from a catheter-based device to a fully implantable device. The open question how we feed it with 5 watts continuously over years or months is still somewhat open, but this will come, and in 10 years they will be kind of like pacemakers today. To understand such very invasive activities, we do a lot of computer simulations, because there are few volunteers who come to the lab to get the artificial heart and stand still to figure out if they work. And that's why we have to simulate what we are doing, and that's why we use sophisticated computer simulations that simulate the whole circulation and other organs to predict and to see what happens. And what you see is here one of my early computer simulations about 10 years ago, before we started these activities. And you see that
that side.
The second part.
The other side. The other side.
Ah, okay. What you see here is the actual course of loss of cardiac rhythm in the ventricle is your blood pressure drops to 0 within 10 seconds. And our simulation showed at the time that if you have such a device in place and you stop, your heart stops beating, then your blood pressure goes down to a mean blood pressure of 55 to 60, which is sufficient to survive. And a short time later, when we started using this device, we saw that this is actually the case. This is such a patient who loses his own rhythm. What you see here is the blood pressure on the lower end. This is 50, this is 80, this is 110. And you see that blood pressure is maintained, and the only activity you see is these dips, which show that the patient breathes himself, which proves that the brain still works in this situation. So computer simulations are a very important tool of progressing in our efforts to build bridges to survival. Recently we had a patient who came in on a Lucas device, and we had this simulation which showed that the Lucas device is able to support blood pressure to a certain degrees, and we replaced with a pressure sensor in the heart, we replaced this Lucas device in the simulation by a catheter-based pump, and simulation predicts that it will work well. And on the right side, this is the patient data where you see that AOP, aortic pressure, is much better if you use such implantable pumps than if you use compression devices. And this means that the patients who get such a treatment end up usually in our intensive care unit, where you have you have a left ventricle, a heart assist device console, you have a temperature console, you have a neurology monitoring console, you have ultrasound monitoring, you have a ventilator, you have lifestyle monitor, you have TV support. So we are able to maintain most organs at the moment except the brain. Sometimes the heart has two chambers pumping individually. Sometimes the right heart also fails before we have supported the left heart. And what I show you here is recently the first worldwide patient who got a dual heart assist device, cross pump. This one pumps blood from the left ventricle to the aorta, and this one pumps the blood from the vein to the pulmonary artery. So we have a complete circulation replacement. And we did this because one device was not sufficient. What we saw is in our monitoring, we saw a nice improvement, and in the end, we have now a 3-year follow-up on this patient. We're very happy to survive. Originally, the company producing these devices was not happy that they implanted this device in this patient, because they said this guy will anyway die, so he will produce a failure for our device, which was not the case. Now, assuming you have a perfect mechanical heart support, why could the patient still die in the intensive care unit? The first is the brain damage prior to support, and this is the bad side. Often we are successful in re-establishing organ function, and just we have a brain dead patient in the bed with no circulation in the brain left. And even cryonics would not help him, because there is no way to bring any solutions to the brain in this situation. Patients may die of complications, this is rare, fortunately, but very often they die of systemic inflammatory syndrome. And this is something which is very poorly understood. In my field, intensive care medicine, there are about 100 clinical studies trying to influence this syndrome. In mice, we are very successful in kind of stopping this. In humans, we have failed. All studies are negative. And this is something that occurs if there is a major insult on the body. This triggers this systemic inflammation, and it will hit back and lead to multi-organ failure and final patient death. So we have patients who are cardiovascular stable from the heart, who have maintained brain function and die of this uncontained inflammation. And then we have also some patients who have a bridge to nowhere, because They may be too old to get a heart transplant, who may not qualify for another mechanical device where we kind of are able to maintain life for a certain period, but then we don't know what to do more. Time is critical. We have the golden hour. If we act right in the golden hour, we have good chances to do something good. If we wait, the patient is dead and we have lost. Now, if you want to avoid death in our main disease, coronary artery disease, then this means that we need to have such things in the hospital, but it particularly means that we need to have an improved pre-hospital management. Because if the patient loses this golden hour before he comes to the hospital, it's difficult to help him. That means establishing a system that brings the patient to the treatment, or the treatment to the patient, is critical here. And then come also all the other risks you run if you have a heart disease, which come at certain times and which need to be taken care of. And that's why we have introduced the telemedicine concept here. A few years ago, if the patient calls the ambulance will go to him, 7 minutes in Basel. And what the guy will do in the ambulance, he will send immediate 12-channel EKG to the leading cardiologist of the cath lab, who can decide what to do with this patient. And this is important because in the old times, usually the patient went to this hospital, and then he went to the emergency room, and the doctors then found out this is myocardial infarction, so let's call the other hospital and discuss with the guys if there's something. What we have seen is that just implementing such a system saves you 40 minutes of very precious time of your golden hour. So the patient now goes directly to the cath lab. He doesn't see any other ward, any other doctor. He just goes to the place where the treatment is applied. For example, cardiac intervention like here. Now, we also do cooling in our intensive care unit in a little different way than you are doing it. I was introduced to cooling by this guy. This is Oswald Oelz, senior author of this journal article, New England Journal of Medicine, Prevention of High Altitude Pulmonary Edema of Inhibited B. And you know from the paper title and from the photograph behind of Himalayas that he's an extreme mountain climber. And I was with him on several of the highest mountains in Switzerland, and he's an interesting guy because he had his medical side and his mountaineering side. One day he came back from his Himalaya trip and needed to kind of put his feet on the table for every day to keep them dry, because somehow he fell down a snowy rock and was lost there for a night. And what you see is the typical reaction of the body to freezing. So first the tissue becomes black, but the body is good. It makes a barrier to this tissue. You wait 4 months, and after 4 months the dead tissue drops off. Now this was very impressive at the time, but it's also an important message. This is what we want absolutely to avoid in the brain. So we want to avoid to have a body which makes a kind of nice shell around a black brain in the end. And so I think this is the key topic for the cryonics community, how to kind of plan for this future. The day when your patients come back from their deep frozen state, what will be there in the brain? Will it look like that, or will it look much different? So emergency management of catastrophic events in intensive care medicine means something happens. We try to make the patient just survive and maintain life. And then there is a second aspect which we would like to do, we would like to precondition the patient before something happens to make the catastrophic event less dangerous. This may be repeated ischemia, reduces the size of myocardial infarction, and so on. The problem is nobody knows when catastrophic events happen, so it's difficult to do before. And then we also know that just surviving is not enough, because a significant part of damage to the body occurs during recovery, which is a reperfusion injury, hyperoxic radicals. There are a lot of biologic events which will kill tissues which is not yet dead at the moment when it's reawakening. So we're also looking at the post-conditioning concept, how can we minimize secondary damage. And it's very important to know, even if there is recovery, how much recovery is there. And if you imagine of yourself what recovery would you like after being severely sick, you probably would prefer the uppermost goal of having full recovery of your brain and not just being a patient in a chronic care institution which is unable to think. So we know that hypothermia, moderate to mild hypothermia, meaning 18 degrees to 30 degrees, is effective in cardiac surgery. There are hundreds of studies showing that. We also know that in the brains which are most capable to recover, which is in the newborn and in the baby brains, it's very good if you need to do a heart operation on a baby to have the baby hypertensive. We also know that time of hypothermia is critical for IQ development. And the number is about 4 IQ points per 10 minutes. And that means it's not a question of live and die, it's a question of remaining intelligence after such severe interventions in the body like circulatory arrest and hypertension. So also something to consider in long-term planning of cryonics. Then we see the reperfusion injury. What you see here is a computer tomogram of a patient with stroke who got revascularization. This is helpful because it tells you the right part of the brain did not see any damage, it looks perfectly normal. Now if you have a stroke and you make a computer tomograph, you see nothing in the first 24 hours. So unfortunately brain imaging is not good to detect structural damage to the brain early on. Now if you have the reperfusion, you solve the problem and you make an image of you the day later, then you see this very bright area which is an expression of loss of vascular permeability and of secondary damage to the brain. So we can image the secondary damage, but we are not good in imaging early damage except we have functional imaging. And functional imaging only works in working brains, working hearts, and not in the frozen state. In patients who got CPR resuscitation outside or inside the hospital, we had some data showing the value of mild hypothermia, 33 degrees for 24 hours. And this is the key study, 2002, New England Journal of Medicine, so the highest rated medical journal, which showed that in the red box, neurologic outcome with minimal or no disability was much better in hypothermic patients compared to normal hypothermic patients. This was a landmark study. It changed the practice of medicine, but if you are a little bit critical, you also see that 77 patients, 40 of which got 30 of which got, or 40 of which get hypothermia, are not a big number of patients to be sure of anything. And this led to the RINS trial. If you have a circulatory arrest outside the hospital, you need a lot of cool, and this will help your brain. This is the hypothesis of the trial. It was randomized, so half of the patients got it and half of the patients did not get it. And the very disappointing result was that standard care is better than hypothermia. So it seemed that by using early hypothermia in patients, by giving cold fluids, actually may damage your patient and not help him. And so this raised a lot of question mark. Where is the truth? What should we do now? And there was a follow-up study in the New England Journal. Now, not comparing hypothermia versus no temperature management, but hypothermia versus temperature management with 36 degrees. This was based on the hypothesis that maybe it's not the normal temperature which damages you, but the fever which often develops in the first days in the hospital. And what they saw is that there was no significant difference between the two groups. So cooling was not beneficial for the brain, it was rather the fact that we avoid the fever in these patients that helped them. Why is that? We know that in animals cooling is good for the brain, but in a patient you have a mix of effects. You may have a benefit on some organs and a risk on other organs, for example infection, cardiovascular instability, multi-organ problems which are induced by hypothermia. Now, if you only go down to 33 degrees, this is a mild problem. If you go down to 28 degrees, 22 degrees, 0 degrees, this is a much more severe problem. So there is a bunch of challenges, not only to the temperature lowering side, but in particular to the recovery side also. We are using cryotherapy not for maintaining life, but for killing tissues. this is one of the most effective physical means. We have to kill the cells if they are not specifically protected. For example, we use cryoballoon ablation in the heart. We have these balloons which we can cool down to -80 within a few seconds, and we use them to contact certain tissues in the heart which have abnormal rhythms, like here, and the tissue which conducts the electricity for the abnormal rhythm can be blocked, and the patient can be treated by such cryotherapies. So we would like to learn more about what actually happens with these, what can we do to have patients survive. There are, you know, from the media, there you certainly read the Business Times. They also do it about once every 10 years. So we have the tardigrades, these small animals that can survive everywhere, even in the Arctic frost for a long time. We have these nice desert snails which can be resuscitated after 3 years of no water. We have the concept of anhydrobiosis, so if you extract the water from a cell and maintain a situation where the cell membranes are not much changed, you may be able to recover the life in this cell. In experimental research which we do in our group, the best experience we have is high pressure freezing. We apply 2000 atmospheres of pressure to a tissue and freeze it down. Now, as you know, ice expands during freezing, so if you have a very high pressure, this expansion, this crystallization does not take place, and that's the technical base for some of the nice images which I show you at very high resolution for maintaining tissue integrity. Now, my view of the medicine of the future: what do we need? What are the enablers of this future? We know we have achieved much. I have shown you that, but at the same time, you see myself working here 30 years ago in this Congo hospital in Eastern Congo. We have also the low-tech problems in medicine, and if you look at prolonging life, the cheapest way to prolong life is probably to double the lifetime of 40 years in Central Africa, compared to double the lifetime of European citizens or American citizens. We have seen in medicine spectacular successes. We know the causes of most diseases. We are not very good in healing. We rather transform acute disease in chronic disease. So if you have myocardial infarction, you will swallow aspirin and other drugs for life. We have not yet found the important aspect of individuality in disease. We cannot cure hypertension, we cannot cure diabetes, we cannot cure many important diseases. We cannot eradicate measles. Despite the Americans did it, sometimes the Europeans have re-imported it. So we need to move toward the knowledge-based medicine. We need to understand better what we are doing. And this is important for traditional medicine, this is important for futuristic medicine, this is important for cryonics. We need to eradicate, we need to personalize, to understand the systems aspect. We need to do it at the price we can pay. And so I would like to show you a little bit what do we know. We know that all laboratory mice are the same. And all humans are very much different. So the difference between you and your neighbor is about 1% of his genome. There are more possible human variants than there are atoms in the universe. So the differences are much more than we were aware of. We also know that this difference is not just the genome. Identical twins are not identical at all. There are epigenetics, environmental, random process in development, many reasons to make you different from what you are, many causes to make you different from your clones, potentially. We know that every disease is different, every cancer has a different genomic background. We know in relation to cryonics that the brain is particularly vulnerable to circulatory arrest, and unfortunately our imaging methods are insensitive. Computer tomography is not worth much in clinical practice of today, and magnetic resonance imaging does not work well for frozen tissues because it's, in principle, it's imaging water protons and their motion. So there is little way to really find out what's going on in a person after a circulatory arrest, either due to a spontaneous event or other. And predicting neurological recovery after arrest is very difficult with all clinical methods. This is our big headache which we have. We have a patient who is in our intensive care unit for a week. He's in deep coma. Everybody wants to know, will he survive, will he recover? We just don't know. The only sure predictor of recovery is recovery. So if the patient recovers, we are happy. If he doesn't, it's difficult. We also know that disease occurs at sites. This is important for tailoring therapies, and drugs tend to work at other sites. Namely, if you have a painkiller, it will not only heal your knee pain, it will also make you a gastric ulcer, kidney problems, and hypertension. We know that barriers in the body are very important, and one of the most difficult barriers to overcome is the blood-brain barrier. Pancreas also is a very important barrier. So potentially, if you try to do cryopreservation, the one organ which is not protected may remain the brain. And this is probably not the ultimate goal of the efforts of investing in patients' mind. Nanoscience will be an enabler of the medicine of the future. This is my nanoscience research group, and the message I want to say you, this is a very interdisciplinary endeavor. Otherwise you cannot find out what happens. If you are monodisciplinary, you just miss the important concept of what's going on. We can use nanotechnologies to look at tissues at very high resolution. This is a living cell in a living artery we looked at 10 years ago, and we reached resolution which by far exceeded what could be done in the times by other methods that allow to look at living table. We can use nanomechanics as sensors, for example, to take the patient expiration, the breath of the patient, to make diagnosis by looking at the bending of very small capillaries exposed to this breath. We can predict diseases. We can make use of the super resolution microscopes which break the optical the resolution limit which we believed in until 20 years ago, until they found that that's actually not a barrier, it can be overcome. And we also need micro and nanofluidics a lot, because all body is in water, all life is in the water, and we need to examine very small amounts of water to make a broader range of diagnosis. We are applying nano for diagnostics currently in a project not only here but also in Africa. Here you see one of our PhD students fighting with one of the practical problems of applying medicine to Africa, which is the main route between Mombasa and the Atlantic Ocean. So the highway is blocked at the moment, and nevertheless it's important to find ways to diagnose these people, to treat them. We are working on novel therapies based on the nanotechnologies. We are moving from drug molecules to nano-sized drug aggregates, to targeted transporters, and to intelligent nanosystems. And this is like the Lego game. Conventional drugs are like Lego pieces. Everyone is the same, everything is the same. You can have a big bag of Lego pieces and it's a little bit boring. But if you put them together, this can become very interesting. And that's what we are trying to do. We are integrating increasing functionality at the nanoscale, and this may mean receptor targeting, imaging, gene delivery, RNA inhibition, sensing at the nanoscale, switching at the nanoscale, delivery of entire metabolic pathways, theranostics, meaning therapy and diagnosis at the same time, remote control of nanosystems, composite systems with coupled functionality, artificial organelles, of which I will show you some now. If we start with certain materials like these polymers thematically shown on the top, there is a process called self-assembly. These molecules, they assemble to larger structures. And for example, they assemble to micelles, to small balls, or they assemble to hollow spheres, or they assemble to tubes, or they assemble to a dozen other possible morphologies. This is not observed and understood if you study a single molecule. And this is a very important concept in my research. This is the emergent properties of nanomaterials. Complex systems may be very different then the basis of what we have. And that's what I see in my research as a kind of structuring feature of life, emergence. Combination of things produces something very different than we have it before. And that means also my understanding is that the reductionist approach of science is a pitfall. We can try to reduce something to kind of its minimal ingredient, but this minimal ingredient may be less than we have it in the full organism. We see a lot of emergent properties in nanomaterials. Shape cannot be predicted if you look at the molecule, surface effects, fluorescence effects, surface plasmons in optics, complement activation, immunogenicity. So a spectrum of flowers which are interesting and not understood by looking at it in the reductionist way. It's a fascinating, rich and important field of research. Now, we are constructing targetable systems with the goal of finding a disease, for example, a cancer cell, docking there, and then treating this diseased cell specifically, and not working on remote tissues. And if you do this disease targeting, we see a strong change. Even if you use a conventional drug inside such a targetable nanocarrier, you see a several hundredfold increase in efficacy on the disease, and the side effects on the remote tissue disappear because these particles never dock on the healthy tissue. We have looked at this in cancer models, means human cancer cells growing in experimental animals, and we see that such nanomaterials are very effective in targeting cancer. And in my particular field, cardiovascular disease, we also see that it's possible to target such nanosystems to the arteriosclerosis, which occurs in certain mice. We can highly specifically target such cells involved in that. Now, the body is very clever. If we have a cell which is infected by a virus, then the body has the T lymphocytes. The T lymphocytes recognize the self, they recognize the foreign, and then they shoot the lethal kiss, and this infected cell is dead. And we would like to learn from this intelligence in what we are doing in nano engineering by creating nanosystems which can sense, which can affect, and which have some power and some logic built in. And in the last 10 years we have seen that there is a number of stimuli which we can use, from pH to redox to enzyme responsivity to internal temperature sensitivity. We can also use external switches like light, ultrasound, electromagnetic waves, and so on. And here, for example, we have created such a nanosystem which is able to a target cell. You see that it reaches those blue cells up there. If we do the targeting, we see that we can kill the targeted cells, but keep the non-targeted cells alive. Now we can add the light switch functionality, which means that in the dark the system is inactive, and if you switch the light on, you can target the killing on these cells. And what we see in comparison of many different strategies is this green one. Combination of light and receptor targeting is by far more effective than whatever we see in other controls. It's possible to use such targeted nanosystems as sensors. So they become shiny if they encounter a specific signal we are looking for. And this is important to understand the metabolic background, for example, of tumors still in situ, so we don't need to cut out the tissue to figure out what's going on inside. We can target such a nanocarrier there and look at the light coming out of the tissue, fluorescent light, to determine what's going on. It's possible to use such nanocarriers to switch genes off, like we have done here for a gene which can produce green fluorescent protein in cells. And what is also interesting is you can use such nanosystems, as I show on the top, to build artificial organelles. An organelle is the subunit of a cell. It has its own biochemical composition. It's very important for the function of this cell, and it's efficient in certain hereditary diseases. And what we have shown here is that if you have a cell which has a certain metabolic capability, shown in green, you can produce a synthetic polymer organelle, You can send it there, and then you can feed it with precursors of a material which are then metabolized in this synthetic organelle in this situ. So this is a step from bottom up to kind of synthetic repair of defects in cells, and it may also stimulate your fantasy of other things that can be done. So the futuristic idea would be to make you, to give you some cells which are green and which allow you to live from the light only. So this is a long fantasy of mankind. There is a famous person who died nearby because she tried to do that. A short word about computer simulations. We cannot understand the complexity of the world by looking at a few samples of it. And that means we need to look at many samples of it, and the best way, a good way to do that is by simulating it. So we are simulating many of our things. Up there you see simulation of such a nanocarrier, which is also looked at in transmission electron microscopy in the United States. And here we look at this system in the wet state in water ice with high pressure freezing. What you see here is an object which has 20 nanometer size, so it's very, very, very small. We are at the range where we can look at individual proteins with the magnification of about 10, and you see the absolute absence of ice crystals everywhere. So if you would like to have a tissue for analysis, this way of freezing is the way to go. I have no idea how you could make a chamber for a patient to freeze him at 2000 atmospheres, but everything else in our case is just destructive for the microstructure. We are modeling polymers, so we are modeling single chains, then how they self-assemble. At the same time, we are modeling proteins occurring in the body, and we are studying their intermolecular interaction to understand how to design the nanoparticles in a better way to avoid or induce interactions. We are studying nano-microfluidic systems for optimal performance in diagnostics, and then to build these nanosystems in real life. We are doing computer simulations of the circulation. This is one of the models we use for the pump. Here you see the green one, not the blue one, is the pump introduced into this left ventricle, and we compare it by other devices like ECMO pumps, like intra-aortic balloon pumps, to understand the differential effects of such systems. We apply machine learning, artificial intelligence to shock, for example, to measure cardiac output based on a minimally invasive numbers. We are using computer simulations of lung function to improve our treatments, and some people are also interested to use these simulation environments to other questions, for example to the social interaction question. And somebody actually used these frameworks to study the interaction of prey and their hunters in Africa. And so what you see is that this is a group chase and a group hunt of lions going to a group of prey, and they look at protective effects of the size of the herd and the size of the lion pack to figure out, are there situations which are good for the prey and are there situations which are good for the lions. And these simulations actually explain various things observed in nature. Now, I'm not an African hunter, but what this shows is that the application of simulation to questions, social interactions, is taking place more and more, and that's what we are doing currently in a project looking at malaria transmission in Africa. In this topic of simulation, you may have read this paper, you may not. If you have not, do it, because it's very stimulating food for the brain. What does it say? So, very probably people in the future will do simulations. Now, I agree with him, because we are already doing simulations. And then he argues that one of the following three arguments is true. Either human species will be extinct soon, before reaching the transhuman stage, or post-human society will not run simulations, or we are almost certainly living in a computer simulation. Now, this means you are probably only a computer simulation. And myself also. If his precondition is true, and his prior assumption is the informational view of man is true. So, this is an important aspect because it's really challenging to our minds, and it's also really challenging to the assumption of the transhumanist thinking. So the question, what is man, what is life, what is a person, and what is truth, is an important one. It's for you important. For me it's also important personally, but it's also important for my patient care. Because in particular medicine there is a strong link between science, worldview, and medical practice. Now, we have the patient-doctor relationship, the decision-making in the hospital, we have the suffering, the dying, the prenatal diagnosis, the unborn, the mentally retarded, the eugenics, the dying, the euthanasia, the cost problem, the handicap. So we have plenty of real problems in daily life. And most of these questions depend on a unique question, and this question is, what is man? If man is a machine, if man is a machine only, if man is a responsible being, is man's behavior fully predetermined by physical laws like Laplace, Heisenberg, Gödel, or is our behavior fully predetermined by genetics and environment? Are we actually independent thinkers or just machines producing a series of electrical activations? Are we a random occurrence in the history of the universe created by intelligent designs, our own future makers? So the answer to this question will give you a response to what you're doing to yourself and what we are doing to our patients. And that's why it's a very important question, and in many aspects it transcends kind of experimental science and current knowledge. So if you look at medicine in history, then question what is man was answered early. Man is the creature of particular value and dignity. So healthcare was an expression of faith and societal responsibility, leading to the ethics of medicine. Man was seen as a mechanically functioning machine which could be mechanically repaired. This was the war surgery, you cut off the diseased arm. Man was seen as a person that is amenable to synthetic and natural substances, so pharmaceutics, internal medicine, and now we are living in the age of nanoscience, and the question is what remains? Remains everything true? Do we reduce this to a specific insight? And there is this question from a different standpoint, what is a person? Reductionist versus emergence. So the reductionist approach could be labeled as the H- approach in contrast to the transhumanist view of the H+ approach. So the essence of man can be reduced to information. The body is in principle disposable. The historical roots of the thinking are old. They can be seen in the Neoplatonists about 1900 years ago. And being connected to your past is the current statement, maybe stated by Max Moore. It may be a new iteration of this kind of rather reductionist approach to what makes man. There is the emergence view, which rather looks at inseparability of body and mind because of the claim that a mind functioning on a body may make more to the two than an isolated point of itself. This is also an old idea. If you look at the biblical story of made from the soil of the earth and you made it with the breath of life, somehow points to this view. And I just would like to reiterate what we believe of being a person really makes our life and makes my clinical practice. The natural scientists have always shaped philosophy. Descartes, all matter is divided into small particles driven around in the sky by platform vortices that carry the planets around. So he was a scientist and he had some strong philosophical statements. I think, therefore I am, so the basis of humanism. Unfortunately, experimental physics do not fully support his science. So unfortunately, it does not claim about his philosophy. Pascal was a engineer, scientist, philosopher. Newton was the fundament of the so-called scientific method, and he was basing his science on the concept of absolute space, absolute time, absolute motion, unified in the natural laws. Unfortunately, his fundaments of his science were shown to be not exact by Poincaré, Lorentz, Einstein a century ago. There is no independence of space and motion, no absolute time, no absolute space. Laplace looked at the universe as a big billiard game, and he said, give me the position and velocities of every particle in the universe, and I can predict every time point in the future. And that's why he had no need of the God hypothesis in his discussions with Napoleon. Unfortunately, Heisenberg showed also 100 years ago that he was wrong. Büchel was an interesting person. At the end of the 19th century, science had the impression that now we have reached the end of scientific knowledge, we know everything. And he said matter is indestructible, eternal, and with absolute certainty, immutability of natural laws, with the most absolute truth and with the greatest scientific certainty, we can say that there is nothing miraculous in the world. The world's mind, spirit, thought, sensibility, volition, life designate no entities beyond the material. Unfortunately, his basis, matter is indestructible, was shown to be wrong 10 years later. 20th century, we have Einstein, who was a physicist and a philosopher. Now, 50 years later, Heisenberg said the great difficulty which even eminent scientists like Einstein had in understanding quantum theory shows that Einstein seems not to be regarded as the one that has the only truth. Heisenberg showed his uncertainty principle and thereby undermining Kant's argument that nature is causal. Gödel, in my view, is one of the most important persons in science in the last century. He proved mathematically that there is no mathematical theory that is complete and free of contradiction. And it's a very important finding because this is the purest of all science, if you want, which proves that it's impossible to fully cover the world that it is by itself. And this has profound implications of our understanding of science. So science is not closed like in the times of Laplace. It's open in a scientific view. Hawking, the famous physicist, had very strong statements about black holes and predictability of the future, and he reverted his stance of losing a bet with a colleague a few years later. What can we learn from it? We can learn from it that science, medicine, future is a very interesting topic. Don't rely on scientists to look in the future. That's what Niels Bohr told us. Prediction is very difficult, in particular if it's about the future. So we're happy to live in an era where we can be open and not need to be bound to fixed conditions. Let me just tell you a short definition of faith. Confidence in what we hope for. Assurance about what we do not see. And this somehow expresses different faiths. This expresses classical faiths like Christianity. This expresses transhumanist faith because the community is very confident in what they are hoping to see in 100 years from now. And we see that this kind of faith has also been translated in words, in kind of a belief statement, to follow their terms, in strong statements of philosophy. So what I want to show is that medicine and science are very interesting fields, and typically they are overlapped by a second layer of things which you believe. I believe that life is a very precious good, and it's worthy to be sustained by all the technologies we can achieve. So I can really say you're doing an important job in thinking about how can you can you have a beneficial impact on individual life. On the other side, I am not convinced that science reduces to a materialistic view of the world. I believe that man is creative, powerful, intelligent, called to freedom and joy, called to make a difference for the world. That's why we are investing also our into selfish and proud, and this is sometimes a problem. Now, from a medical doctor's view, what could you do in cryonics to move them forward to clinical application? I believe it would be helpful for outsiders like me to clarify concepts and to develop testable hypotheses. For example, the concept of structural damage, ice crystals, and functional destruction that you introduce if you do protein cross-linking plastination in a tissue due to preservation should be worked out very clear. And now the whole kind of cryopreservation story looks rather homogeneous, but these are two completely different chapters, and I think it should be stated like that. Then for me, the question of short-term hibernation, how can we have a patient survive until we have repaired his disease? For example, the patient has got a heart transplant or whatever. And the long-term storage for repair and the long-term storage for upload are different topics. And I'm hoping to see more clarity in the terms and definitions and efforts there. What about whole body vitrification reanimation in mammals? We have heard that there are 150, 200, a few hundred people now in the cryonics institutes, but knowledge about their stage is very sparse. We have some information about computer tomograms, as I know, but these computer tomograms do not tell us about the chances that these brains ever will recover. Now, if there is significant ice damage to these brains, I'm very pessimistic about the outcome. On the other side, I think it's an important question, and before going with cryonics to 1 million people, we should have much more profound about the patients you have now. Can we document functional recovery of the brain in mammals that have been frozen, vitrified, reanimated under optimized conditions and protocol? If we cannot recover brains from optimal conditioned small animals, chances are near to zero that this will ever happen in man. How about volunteers who then donate their body to be cryopreserved for a systematic protocol comparison followed by state-of-the-art images and biopsies? There are parts of the brain which are not as important for function as are others, but such findings would really help to understand are you doing the right thing or you are just running in the wrong direction. Autopsy. This patient would lose his chances, but would he have had chances? So he might predict chances for other people in this condition. And then experimental any evidence for body-mind dualism and separability. This is highly interesting because out from a worldview, from a faith, you are producing testable hypotheses. And I'm looking forward to see simulations and experiments really telling us more about what man is. And there are data and patients in your hand who help us to educate about this future. And I'm eager to hear about evidence-based cryonics this afternoon. So thank you very much for your patience.
Gosh, that was a tour de force from ICU treatments to lion hunting to ethics to nanomedicine, and Patrick Hunziker has not even mentioned a fraction of his activities. He's, amongst other things, 10 years ago you founded the Foundation for Clinical Nanomedicine that every year organizes a huge conference here in Basel around May, June time frame that usually has about 3 Nobel Prize winners as attendance. So you told me, would you like to run the risk to take me as a speaker?
Yeah.
I think absolutely, let's give him a hand again. From the audience?
Yes, I was very impressed with the range of your work. And of course, we're particularly interested in how it reflects on cryonics. So I have one question. You mentioned it's important to distinguish in cryonics the structural damage from the functional damage. if you think about what nanomedicine could achieve in the future,
That's not the answer.
what do you think would be more easy to reverse? The ice crystal damage, or the structural damage, or the functional damage?
Now, I believe if you're going into protein denaturation, which is typically done by cross-linkers, with which we have worked 20 years ago in another context, then this will be very tough. I don't believe that we will be able to undo generalized cross-linked proteins in the brain. There are some chemicals like cyclosonic acid, which lead to reversible cross-linking. But you need to have this at a very high concentration. So in the end, I believe that the fixation aspect, if you kind of, the coarse way is you pour formaldehyde everywhere, everything just freezes down in its state. It's very good for doing microscopy, and it will be impossible to recover anything. On the other side, cellular damage by ice crystals. There I really see problems in repairing by even the most futuristic nanosciences, because most of your cells in your brain will not be functional, and so the task reduces mainly to a kind of reconstruction of the whole heart, and their biology will be much better in building hearts in embryos than so in humans than rebuilding hearts by technologies. And something I have not discussed is the whole question is how much can technology replace biology? And this is something we are also looking at in the simulation aspect. Now, if you're trying to do simulations, the key of simulating is simplifying. For example, the single water molecule, 3 atoms, is very simple physically. But its interaction with the environment is most complex. So even advanced atomic simulations with the use of quantum physics and so, they still end up with a 30% of error in their results. And that means you need a huge amount of computation to model a single water atom. But if you use a single water atom, you always have it already there. So using the original at the very complicated stage sometimes is easier than to use a simulation which makes every Lego builds it up in a very complicated way. Computers will become faster, but not infinitely, because we'll hit the law of miniaturization soon. So computer power will not grow exponentially for all the future. So I have no real answer. Both are challenges. Yes?
Thanks for your presentation. Coming back to your final slides about cryonics moving into the clinical realm, I'm wondering, in a context like Switzerland, do you ever see cryonics moving into the clinical realm, being involving medical professionals performing some of these parts of the procedures, and if so, what sort of evidence base do you think would be required for people to agree to get involved in an enterprise?
So typically what you need is an ethical view, an ethical committee permission for doing new things. You need patients, you need personnel who is willing to do it, and you need permission from the hospital. Now, for example, for an ethical committee to agree to something, you need to convince a round of different people from very different backgrounds that you're doing something that has a real chance to do something good. And that's why I have shown a little bit the questions, the task list of what would be done. On the basis of knowledge today, it will be difficult in Switzerland to convince anybody in the ethical committees that this really has a future and it's not just a good idea. So we need to have much more in hand, typically, even to move forward with the device like the ones I've shown you. The other one is that in public hospitals, which usually are the University Hospital and have the best infrastructure, there is a clear political will, for example, not to do assisted suicide, because they say it's not the hospital task to do a suicide, and if you claim that cryonics is not a suicide, then there should be evidence kind of to show that. So I think there are significant hurdles in involving institutions. So it needs,
To make my question more specific, do you think anything less than, say, the revival of a large mammal, a successful revival based on cryonics procedures, would be enough, or could just say, evidence of good preservation?
Most medical therapies come into the clinic by showing them in mammals. So if you can reanimate the cow head and see that the cow still is kind of cow-like, this is a good start. But it needs experimental evidence not only of the freezing activity, but also of the unfreezing activity. And there you have much less data, in my understanding, than for the freezing. Also the fact that to progress, some people need to participate in clinical trials. For example, the question of what to do with these frozen people, or these volunteers who kind of agree to participate in scientific progress by being willing to undergo a limited risk to the benefit of knowledge. This is an open question.
But we do it for embryos. In a way, it's the proof that it works.
No, but the key question is the heat and the propagation of heat through tissues. And the embryos are so small that you drop them in liquid nitrogen and they freeze in a millisecond or so. So it's a completely different question than if you freeze a brain. And freezing rates are one of the key issues, even if you freeze cells. So if you want to freeze stem cells, hematologic stem cells, for example, it's very important to have the right freezing regime in degrees Celsius per time. And this will probably also be important for other tissues. So what I want to say is, for me, a cow head would be much more important than an embryo, because microscopic aspects seem to be very important in freezing and unfreezing project. It's not just a question what genes are inside the cells which are freezing. And the embryos, these are 8-cell embryos, so they are not kind of small humans with a head and leg and whatever. They are just blastocyte stage. Yes?
The question to hypothermia: do you induce hypothermia before restarting the heart or after restarting it?
Now in cardiac surgery, what is done is you induce you put the patient on a heart-lung machine, taking over heart function and lung function. The heart-lung machine has a very potent cooling device. That means you cool the patient down on the heart-lung machine, and when the body temperature goes below 30 degrees, patient spontaneously get into ventricular fibrillation or are put into ventricular fibrillation by an electrical pulse. And then you do the operation at whatever, 22 or 28 degrees, and then first you restart the heart-lung machine, and when the body has reached a temperature of 35, 33 or so degrees, then you re-synchronize the heart by another electric shock, and you look for recovery of heart function. Now, in CPR, in cardiac arrest, it's different. The patient has the arrest somewhere, he gets into the hospital. If it's winter, he's already somewhat cool when he comes in. Otherwise, he gets some cold infusions. And what we usually do, we put a central line which has a cooling element on the top, which is quite effective in controlled cooling and rewarming of these patients.
So in heart arrest in the field, you start hypothermia first.
No, what I want to say is, usually in Switzerland is a cold country. So average temperature is 10 or 12 degrees. And that means in most occasions, patients anyway cool down before they come to the hospital. And the studies which tried to add additional cold infusions, they failed to show benefit.
Okay.
So there was no value in kind of giving the people 2 liters of 4-degree cold water, and that's why it's not routinely done.
And in summer, at 30 degrees?
Well, we have many lakes. 20 degrees.
Thank you.
Okay, thanks again. The next speaker will be David Gifford.